BPH. The prostate gland is a walnut-sized gland located at the bladder neck that surrounds the urethra. The gland is responsible for producing semen in men. BPH, or benign prostatic hyperplasia, causes pressure on the urethra, and there are symptoms and problems that result from this. There are several signs of BPH. Urinary frequency often with incontinence, day and night. A weak urine flow. Pain during urination, and even lack of urinary control. At around the age of 50, 15% of men suffer from BPH, so it's recommended to have a yearly examination to determine the prostate size. In the early stages, the treatment is medication. One type of medication relaxes the muscles surrounding the urethra and eases the flow of urine. Another type of drug mechanism reduces the concentration of a derivative of testosterone. There are also natural remedies that ease symptoms of the disease. If symptoms worsen to the point of pain, kidney damage, bleeding infection, or obstruction in urinary retention, surgical intervention is required. The most common procedure option is transurethral resection of the large prostate via the urethra. Other options include electrovaporization, laser therapy, and microwave therapy. In cases where the above methods cannot be performed, open surgery is performed to remove the obstructive tissue through an incision in the lower abdomen. If you're diagnosed, you should reduce the amount you drink before going to sleep, reduce your alcohol and coffee consumption, and urinate at regular times. For more information,
the male urinary system is made up of the kidneys, which produce urine, the ureters, connecting the kidneys to the bladder, where urine is stored, and the urethra, the exit passageway from the bladder. The male genital system begins with the two testes, where sperm are produced. The epididymis is a system of convoluted small tubes leading from each testis and emptying into the vas deferens. After being joined by the duct of the seminal vesicles, the vas becomes the ejaculatory duct, which enters the prostate, where it joins with the urethra to convey the sperm, contained in semen, to the penis. The walnut-sized prostate gland is situated just beneath the bladder and encircles the upper part of the urethra. It secretes alkaline fluid rich in enzymes and prostaglandins. This secretion is important to the survival and performance of the sperm. The seminal vesicles also play an important role in contributing secretions which enhance the sperm's chance of success. During ejaculation, the connection between bladder and urethra is closed, while the prostate, seminal vesicles, urethra, and the penis all undergo rhythmical contraction, moving forward the semen, which is composed of sperm plus secretions from the prostate, seminal vesicles, and minor glands. The aging male is prone to develop enlargement of the prostate, known as benign prostatic hyperplasia, or BPH. The prostate contains numerous small glands which secrete into the urethra, and muscle fibers and connective tissue. In benign prostatic hyperplasia, all of these elements increase, resulting in enlargement of the prostate gland. The first changes in BPH involve proliferation of glandular tissue in the area known as the transitional zone. This is the area immediately surrounding the urethra. New cells are constantly being formed by division. Room has to be made for these new cells by a special process of programmed cell death known as apoptosis, so that in normal health, the number of cells being produced is balanced by the number of cells disappearing through apoptosis. Impairment of apoptosis is thought to be an important factor in causing benign prostatic hyperplasia. As the prostate enlarges, it compresses and distorts that part of the urethra which passes through it, causing disruption to the normal flow of urine. Drugs used in treating benign prostatic hyperplasia act in one of two ways. They either reduce the intensity of androgenic stimulation, or they relax overactive muscles at the base of the bladder and surrounding the proximal urethra. When epithelial cells multiply excessively in either benign conditions such as BPH or in carcinoma of the prostate, they may release excessive amounts of a glycoprotein called prostate-specific antigen, or PSA, into the circulation. Treatment of BPH with drugs which reduce androgenic stimulation tend to lower blood levels of PSA, while treatment with alpha-adrenergic blocking drugs has no effect on the blood level of PSA. The use of anti-androgen drugs is based on the concept that benign prostatic hyperplasia is caused by excessive androgen stimulation. Testosterone is normally converted to its more active metabolite 5-alpha-dihydrotestosterone, DHT. This requires the participation of the enzyme 5-alpha reductase. Drugs which block the action of this enzyme slow down the conversion of testosterone to DHT, and so the androgenic stimulation is reduced. The prostate tends to regress in size. Symptoms of benign prostatic hyperplasia may also be caused by overactivity of the muscles surrounding the exit of the urethra from the bladder and the prostatic urethra itself. These muscles normally receive impulses from sympathetic nerves, which release norepinephrine, causing contraction. Alpha-adrenergic blocking drugs compete with norepinephrine for attachment to receptors in the muscle fibers at the base of the bladder muscle and in the wall of the urethra. This lessens spasm and encourages muscular relaxation. One theory is that alpha-adrenergic blocking drugs may also encourage apoptosis in the glandular cells of the prostate in men with BPH, tending to restore the balance between new cell production and old cell disappearance. In carcinoma of the prostate, the growth and multiplication of cells escapes from normal control. In addition, there is impairment of apoptosis, the important process of programmed cell death, which normally regulates cell numbers. Carcinoma of the prostate usually begins in the peripheral zone, unlike benign prostatic hyperplasia, which most often starts in the transitional zone, around the prostatic urethra. Unlike the situation in benign prostatic hyperplasia, where cell multiplication is much more controlled, in prostate carcinoma, the malignant cells multiply out of control, begin to invade the stroma, the connective tissue of the prostate, and extend beyond it to the surrounding structures such as the seminal vesicles. Having breached the capsule, the tumor is now able to spread more widely. Malignant cells may invade the lymphatic system, traveling to regional lymph nodes, and then onto the liver and/or lungs. If the tumor cells enter the bloodstream, they may also be carried to the bones, as well as the liver and lungs. Benign prostatic hyperplasia may cause lower urinary tract symptoms, or LUTS. These include problems with voiding, such as hesitating and starting to urinate, a reduction in the stream, a feeling that the bladder has not completely emptied with urination, and dribbling after urination. Nocturia, or increased frequency of urination at night, causing the person to get up more than once during the night, is another common symptom and may seriously interfere with sleep. Sometimes, despite frequent urination, the bladder may not empty completely, causing a large post-void residual urinary problem. This situation requires intervention to avoid problems associated with urinary retention, such as increased risk of infection, bladder stone formation, or cancer development. There may also develop storage problems due to irritation of muscles of the bladder wall and muscles surrounding the proximal urethra, causing the person to urinate more frequently. So, in summary, there are now two major classes of drug used in treating benign prostatic hyperplasia. These are the alpha-adrenergic blocking drugs, which counter the symptoms caused by irritation, and the drugs which reduce androgenic stimulation. As each of these classes of drug works in a different manner, If necessary, they can be used together. The greater the degree of prostatic enlargement, the more effective a 5-alpha reductase drug is likely to be. These drugs may not only reduce the symptoms of benign prostatic hyperplasia, but they may inhibit further prostatic enlargement by antagonizing androgen stimulation in the case of the 5-alpha reductase inhibitors, and by restoring prostatic epithelial.
Your doctor has recommended that you undergo a cystoscopy. But what does that actually mean? The lower urinary tract allows your body to store and release urine. It's made up of two parts, the bladder and the urethra. Your bladder is a hollow organ that expands as it fills with urine. Because it is made of muscular tissue, it can also contract and force called a cystoscope through your urethra and into your bladder. The cystoscope allows your doctor to visually inspect the interior of your bladder. It also allows your doctor to remove small pieces of tissue for later examination, and even to crush small bladder stones should any be present. Any tissue that your doctor removes from your bladder will be sent immediately to a laboratory for analysis. Your doctor will ask the laboratory to check for any sign of cancer or other abnormality. And the nurse will swab the penis with an antiseptic solution. Your doctor will then lift your penis upward. A well-lubricated cystoscope is gently inserted into the urethra, the opening at the head of the penis, and slowly guided inward. When the cystoscope reaches the back of the penis, your doctor will pull the penis downward in order to create a straight path into the bladder. Once the cystoscope is inside the bladder, your doctor will inject a small amount of water through the cystoscope and into the bladder. The water serves to expand the bladder, helping your doctor to better examine the interior. It also helps by washing away any blood or remaining urine. You may feel a sense of fullness as though you need to urinate. You'll be encouraged to relax and not to try to retain the water in your bladder. As the team completes the inspection, they'll be looking for suspicious tissues. If they find bladder stones, your doctor may try to crush these so that they can pass out of the bladder during normal urination. If the team finds a suspicious growth, they will use a special grasping tool to take a sample of the tissue in order to send it to a laboratory for analysis. When the inspection is complete, your doctor will remove the cystoscope and you'll be asked to empty your bladder. Your doctor will probably ask you to wear a temporary Foley catheter. A Foley catheter is a narrow tube inserted through the urethra and into your bladder. The catheter is connected to a bag that is attached to your leg by a strap. While the Foley catheter is in place, urine will pass from your bladder into the bag. You will not need to urinate into a toilet. The nurse will show you how to change the bag when it's full. An appointment will be made for you to return to the doctor's office in a couple of days to have the catheter removed. As soon as the anesthesia wears off and you feel comfortable, you'll be allowed to leave. Your doctor has recommended you undergo a transurethral resection of the prostate, or TURP. But what does that actually mean? The prostate gland is a walnut-sized organ which is part of your reproductive system. It provides some of the fluids contained in semen. The prostate is located just under the bladder and behind the testicles. The urethra, the hollow tube that carries both urine and semen to the penis, passes through the prostate. In some men, the prostate gland becomes enlarged. Symptoms of an enlarged prostate include a full bladder feeling even when the bladder is empty, pain when urinating, weak urinary stream, infertility, and sexual dysfunction. To relieve you and your symptoms, your doctor feels that you would benefit from a surgical procedure called TURP. TURP is designed to relieve symptoms by reducing the size of the prostate. It is also a diagnostic procedure. Tissue removed during a resection of the prostate, or TURP, is routinely screened for the presence of cancer. On the day of your operation, you will be asked to put on a surgical gown. You may receive a sedative by mouth, and an intravenous line may be put in. You will then be transferred to the operating table. Once on the table, your feet and legs will be placed in an elevated position with your knees apart. And the nurse will swab the penis with an antiseptic solution. Your doctor will then lift your penis upward. A well-lubricated instrument called a resectoscope is then gently inserted into the urethra. When the resectoscope reaches the back of the penis, your doctor will pull the penis downward in order to create a straight path into the prostate. Once the instrument is inside the prostate, your doctor will extend a small loop of sharp-edged wire from the end of the resectoscope. Using this tool, your doctor will then scrape excess tissue from the prostate, restoring it to its normal size. Tissue removed from the prostate may be sent to a laboratory for analysis. When the surgery is complete, your doctor will remove the resectoscope. Your doctor will probably ask you to wear a temporary Foley catheter. A Foley catheter is a narrow tube inserted through your urethra and into your bladder. The catheter is connected to a bag that is attached to your leg by a strap. While the Foley catheter is in place, urine will pass from your bladder into the bag. You will not need to urinate into a toilet. The nurse will show you how to change the bag when it's full. An appointment will be made for you to return